Louis. No disclosures. So when we're thinking about PAU and IMH, this paper by Ali Aburahmad summarizes it quite well. PAU we think of as a disruption of the intima. It's really kind of a cratering effect that extends through the media and outpouching. IMH, however, is a localized thickening of the aortic wall, secondary rupture of the vasa vasorum, and then some localized bleeding within that media. They're distinct entities, but can be related. I really like to think of both of them, as well as aortic dissections, as within a spectrum of acute aortic syndromes. And you can see in this Venn diagram, can be quite a bit of overlap. Ultimately, you can have one, both, all three, and then they can all lead to aneurysmal degeneration. So on the top picture, you can see there's a PAU there on the lesser curve. On the lower picture, there's IMH. You can see quite a thick wall of that rind or IMH around the true lumen. I think it is important to recognize that this pathology can occur in both the thoracic and abdominal components. We often think of this really in the thoracic space, but you can get IMH, you can get PAUs in the abdominal aortic space, and they can and need to be treated at times. In terms of diagnosis, typically these patients come in either asymptomatic or with some type of pain. Imaging can be done with several modalities, TEE, MR, but I think CTA really is the gold standard for the most part with really most aortic pathologies at this time. In terms of indications for intervention, that's really the million-dollar question. What do we do with these? There's so many of these that come in, and it's really unclear whether to move forward and try to treat them or actually to just watch and observe. This is a paper that we put together, and you can see that we looked at a whole bunch of different PAUs, and the one thing that would predict progression of the PAU was a symptomatic state. And I would suggest and put forward that I think if someone comes in with a PAU that's symptomatic, it would almost certainly warrant intervention. This was a nice 11-year experience looking at PAUs, and found that patients with increasing pleural effusion were at risk for adverse events. Looking at the literature, they also defined that PAUs with a depth greater than 15 millimeters were also at risk. And this is a patient that we saw had a PAU. You can see a significant bilateral pleural effusions. It begins to worry you a little bit, especially if those Hounsfield units in that effusion start to increase a little bit more and would be a little bit more concerning. In terms of IMH, I think there's been a lot of discussion of whether or not this is a benign process. In reality, I think it is not, and certainly something that needs and warrants careful observation or even sometimes immediate treatment. In this paper, they looked at IMH and PAUs, and they found that there were a fair amount of rupture that can occur with these patients. Predictors of poor outcome included persistent pain, association with a PAU, total aortic diameter greater than 4 centimeters, or IMH thickness of greater than 1 centimeter. Certainly, if IMH extends into the ascending aorta, then it's an indication for urgent treatment. It's managed like a type A dissection. Another radiographic finding that would portend a bad outcome is when when you get that bleeding or contrast enhancement into the IMH space. As you can see here in these 4 pictures, you can see over time it's just some IMH and then that big contrast bulge into the IMH, and that is worrisome for potential rupture. These patients can present with immediate rupture at the time with IMH. You can see blood into that pleural cavity there. And this was a patient that we treated a few years ago. A patient came in asymptomatic with some hypertension, normal looking IMH, and then 3 days later ruptured and was treated emergently. So even though something appears benign, I think the IMH can be more worrisome than not. In terms of management, again, medically, it's pain control, antihypertensive, and surveillance imaging. Intervention, for the most part, is endovascular, TVAR, except for the ascending or arch involvement, and then EVAR for the abdominal component. Looking at this paper of treatment for IMH and PAU, you can see that technical success was quite high, which is not unexpected. Morbidity and mortality, both in hospital and in follow-up, was good as well. The experience is somewhat limited for the most part in terms of the numbers, but again, the patients can do quite well if treated correctly. This was a literature review looking at treatment of PAU with TVAR. You can see the 310 patients, 30-day outcomes were excellent. Midterm outcomes were quite good as well. And again, suggesting that TVAR is an appropriate intervention for this type of treatment. Looking at IMH treatment with TVAR as well, you can see that over time there's a significant aortic remodeling that can occur, which is nice and expected, and something that you'd want to see as your outcome. Some of the recommendations for doing this, treating these patients, are very important. I think first and foremost, you want to think about getting past the area of disease whenever possible. You don't really want to land in the IMH if you can avoid it. You don't want to balloon in that space either. If you're going to land within the IMH and you balloon it, I think there's risk of propagating that disease proximally or distally. And then ideally, you don't want to oversize tremendously in this space, again, because you have to realize it's damaged and pathologic tissue. And so landing an endograft and oversizing it significantly can create and propagate the disease. So in conclusion, PAU and IMH, I think, are a spectrum of acute aortic syndrome. It's not always benign, so you can't just take these patients and assume they're going to be okay and send them home, because they may never follow up for the worst reasons. There can be some predictors of worse outcome, and they need to be noted, and with those situations treated, I think, probably in that hospital stay. Intervention can be warranted, and there are certainly technical maneuvers that are important to prevent new pathology from occurring. Thank you.